Hi guys, welcome to Podcast Med. The topic of discussion in this podcast is errors of refraction, accommodation, and asthenopia. Under this topic, we'll be discussing about errors of refraction, accommodation, and its anomalies, asthenopia and digital eye strain, which is a small topic, and then we'll be discussing about methods of correcting refractive errors. Now, coming to the errors of refraction. Under errors of refraction, we mainly have emetropia and ametropia, hypermetropia, myopia, astigmatism, anisometropia, aniseikonia. Okay, coming to emetropia and ametropia. Emetropia is basically optically normal eye, and ametropia is a condition of refractive error under which we have myopia, hypermetropia, astigmatism. Now, coming to the hypermetropia is also called hyperopia or long-sightedness. It is the thing that it is the long sight is normal and near sight is problematic in this state. Hypermetropia is the refractive state of the eye where parallel rays of light coming from infinity are focused behind the retina with accommodation being addressed. Hypermetropic eye has a converging power less than 58.6 diopter normally. The etiology, causes of the hypermetropia can be divided into 6 types: axial hypermetropia, curvatural hypermetropia, index hypermetropia, positional hypermetropia, absence of crystalline lens, and consecutive hypermetropia. Let's go one by one. Coming to the axial hypermetropia, here the total refractive power of the eye is normal, but there is axial shortening of the eyeball. About 1 mm shortening of anterior-posterior diameter of the eye will decrease the power of 3 diopters. It is 3 diopters of hypermetropia. 1 mm shortening is 3 diopters of hypermetropia basically. Then coming to the curvatural hypermetropia, it is because of the curvature of cornea. It results 1 mm of increase in the radius of curvature. It will result in 6 diopters of hypermetropia. That is axis, length of the axis, here curvature, radius of curvature. Then coming to the third type, index hypermetropia. It is due to decrease in the refractive index of the lens in old age. It can be due to cortical sclerosis like conditions, and it also can be in diabetic patients. Coming to the positional hypermetropia, it will happen because of posteriorly placed crystalline lens. The crystalline lens, if it is posteriorly placed, this positional hypermetropia happens. Basically, position of lens is abnormal here. Then coming to absence of crystalline lens. Absence of crystalline lens is called aphakia. It has high hypermetropia. And then coming to consecutive hypermetropia, it is overcorrected myopia. Basically, if myopia is myopia is corrected, normal vision happens. If it is overcorrected, hypermetropia happens. The quite opposite of hypermetropia is myopia. So this can happen in LASIK surgeries and implantation of contact lenses, ICL, etc. And it can also happen in underpowered intraocular lens implantation during cataract surgery or refractive lens exchange. Coming to the clinical types of hypermetropia, we have discussed about the etiological types: axial hypermetropia, curvatural, index, positional, absence of crystalline lens, consecutive hypermetropia. Coming to the clinical types, we have congenital, simple, pathological, and secondary hypermetropia. Congenital hypermetropia is it is congenital condition. Magnitude of refractive error is high in this. And then coming to simple hypermetropia, it is the commonest one. It is because of developmental axial hypermetropia and developmental curvatural hypermetropia. Normal biological variations of the eyeball may occur in this, and this hypermetropia happens. It can be axial or curvatural. Okay, as the development happens, this happens. Then coming to the pathological hypermetropia, it is because of the atypical or abnormal development of eyes, where the pathologies might be microphthalmus, nanophthalmus, microcornea, congenital posterior subluxation of lens, congenital aphakia. Aphakia is absence of lens. Microcornea is short, like small cornea. Nanophthalmus, microphthalmus, or smaller what is that, eyeball. Secondary hypermetropia, this is a acquired hypermetropia which can be caused by other eye disorders and physiological risk factors. The following can be the causes: senile hypermetropia, which occurs in old age. This can lead to index or curvatural hypermetropias. Okay, secondary hypermetropia, the causes can be varied. First one is senile hypermetropia, which can cause index or curvatural hypermetropia. Then coming to next thing which can cause secondary hypermetropia is positional hypermetropia. It is due to posterior subluxation of lens. Then acquired aphakia. A state of high hypermetropia occurs due to cataract surgery, where there is no implantation of intraocular lens in this, and there can be posterior dislocation of lens in the vitreous cavity as well. Traumatic extrusion of the lens can also happen. This is acquired aphakia. Then coming to the next cause of secondary hypermetropia, we have consecutive hypermetropia, pseudophakic hypermetropia, surgically overcorrected myopia. This sounds exactly like the etiological factors that we have studied, right? Then acquired curvatural hypermetropia. This might be due to post-traumatic or post-inflammatory corneal flattening. Cornea will get flattened post-traumatic and post-inflammatory. Normally, the power of the eye, refractive power of the eye is because of two membranes basically. Firstly, it is because of the cornea, and then it is because of the lens. Okay, maximum power, it is because of the corneal curvature. Then coming to the next cause of secondary hypermetropia, it is functional hypermetropia, which can happen in third nerve palsies and internal ophthalmoplegia, where these nerves will supply the muscles of accommodation in the eye. And then after this, we'll have hypermetropia depending on effect of accommodation. Types of hypermetropia depending on effect of accommodation. According to that, we have two types of hypermetropia: latent hypermetropia and manifest hypermetropia, where hypermetropia is normally corrected by inherent tone of ciliary muscle. Manifest hypermetropia is when it is not corrected by ciliary tone, and it can be of two types: facultative and absolute. Facultative, where it is corrected by the patient's accommodative effort, but absolute, it is not corrected by the patient accommodative effect. Then coming to the clinical features of hypermetropia, we have mostly it is asymptomatic at the start. Then as the power increases, there may be occurrence of asthenopic symptoms. Asthenopic symptoms is because of the sustained accommodative efforts that the patient do. There can be frontal or frontotemporal headache, watering from the eyes, mild photophobia. These are the asthenomic symptoms that we can see. And obviously there is defective vision. These are the symptoms. Under clinical features, we have symptoms and signs. These are the symptoms: asthenopic symptoms and defective vision. Coming to the signs, the size of the eyeball may appear small. Cornea may be slightly smaller than normal. Retinoscopy and autorefractoscopy, they will reveal hypermetropic refractive error. Fundus examination, there is small optic disc and it look more vascular with ill-defined margins. It can also, this fundal examination findings can also simulate. It is similar to papillitis, though there is no swelling of the disc, and so it is called pseudopapillitis here. There will be short silk appearance, where the retina as a whole may shine due to greater brilliance of light reflections. Retina will be shining so much because of light. It is short silk appearance, and when we do A scan, ultrasonography or biometry, there is short anteroposterior length of the eyeball in axial hypermetropia. Coming to the grading of hypermetropia, we have low, moderate, high. Under low, it is less than 2 diopters, less than plus 2 diopters. Moderate, it is 2 to 5 diopters, plus 2 to plus 5 diopters. High, we have more than 5, plus 5 diopters. Coming to the complications of hypermetropia, there can be recurrent styes, blepharitis, chalasia. It is due to infection which is caused by repeated rubbing of the eyes. Then accommodative convergent squint can happen because of excessive use of accommodation. There can be amblyopia development. Development of amblyopia, then it can predispose to primary narrow angle glaucoma. And coming to the investigations and diagnosis, we do retinoscopy, autorefractometry, A-scan ultrasonography. Best method to know the amount of hypermetropia is cycloplegic retinoscopy. Then coming to the treatment of hypermetropia, we'll do optical treatment by giving convex lenses, and the rules of prescribing glasses in hypermetropia are firstly, total amount of hypermetropia should always be discovered by performing refraction under complete cycloplegia. Then will be giving lens and gradually increase the spherical correction at 6 months interval, because a patient cannot immediately adapt to the manifest hypermetropia. What is manifest hypermetropia? As we discussed, it is a hypermetropia which is not corrected by ciliary tone and which may be corrected by patient's accommodative effort. Okay. Then coming to the aphakia. We have discussed everything about the hypermetropia. Now we'll go with aphakia. Aphakia is what? It is absence of crystalline lens from the eye, basically. Lens is absent in the pupillary area. The causes of this can be congenital absence of lens. It is very rare, but surgical aphakia, because removal of lens is commonest presentation. Normally, this is most common thing. Aphakia due to absorption of lens matter. It is rarely occurs after trauma in children. Traumatic extrusion of lens from the eye also constitutes a rare cause of aphakia. Optics of aphakic eye. Following optic changes occur after removal of crystalline lens. Total power of the eye is reduced to 44 diopters from 60 diopters. Normally it is 60 diopters and it will be reduced to 44 diopters because still the corneal power is still present, so it is still there. 44 diopters is still there. Because that 15 diopters almost is contributed by lens in normal eye, and anterior focal point becomes 23.2 mm in front of cornea. Posterior focal point is about 31 mm behind the cornea. Accommodation is lost fully, and clinical features can be defective vision, erythroplasia, synopsia. Defective vision, as we all know, and erythropsia and synopsia. It is seeing red and blue images. It is because of excessive entry of ultraviolet radiations and infrared radiations in the absence of lens. If the lens is not there, this rays will enter too much into the eye. Then coming to the signs of aphakia. There can be limbal or corneal scar which is present in surgical aphakias. Anterior chamber will be deep than normal because there is a gap, cleft left because of absence of crystalline lens. Then we have iridodonosis, which is tremulousness of iris, which can be demonstrated. Pupil is jet black in color. And then Purkinje image test shows only 2 images. Basically, Purkinje images are formed, total number of Purkinje images which are formed are 4. In that, 2 are formed by cornea and 2 are formed by lens. Corneal, anterior layer of cornea, posterior layer of cornea. Each layer forms 1 picture. And then in lens, anterior capsule and posterior capsule. Each layer forms 1 picture and image. So out of these 4 images, because there is no lens, there will be absence of 2 images, and there are only 2 images that we can see. Under fundus examination, we see hypermetropic small disc. Retinoscopy and autorefractometry will reveal high hypermetropia. Then coming to the treatment, it is to correct the refractive error by convex lenses. normally. Spectacles are used. Um, Even though we use spectacles in this, there can be a chance of pincushion distortion because it is a high hypermetropia. When high power of convex lenses are given, there are chances of distortion. In this, we see pincushion effect. If it is myopic eye, we see barrel effect. Okay. Different kinds of distortions that we see because of high power of lenses that we use. And there can be presence of roving ring scotoma, which is jack in the box phenomenon. Please google it or see it in the chat gpt for better understanding. Now I'm not going to explain because a lot of things are there to explain in this chapter. Then coming to the next treatment, we can give contact lenses for this as well, but it is most costly and it is very complex to wear it. And because especially in old age mostly cataracts will happen, and cataract surgery there will be removal of in lens, so it is a little complex to them. Then can be corneal complications, or else we can even put intraocular lens. We can implant intraocular lens to correct aphakia, and we can do refractive corneal surgery as well. It is hyperopic LASIK, where secondary IOL cannot be. It is this refractive corneal surgery is preferred in hyperopic LASIK, where there is no chance of implanting secondary intraocular lenses. Coming to the next thing, we have discussed hypermetropia, aphakia. Now coming to the pseudophakia. The condition of aphakia, when corrected with an intraocular lens implant, it is referred to as pseudophakia. Basically, it is intraocular lens implantation. That's it. It is also called artiprakia though. The signs of pseudoprakia include surgical scar, which is seen near the limbus. Anterior chamber is slightly deeper than normal. Mild iridodonosis, tremulousness. Purkinje image test shows 4 images in this. Pupil is blackish in color, but when light is thrown in pupillary area, shining reflexes are observed. There is presence of IOL confirmed on slit lamp examination. Visual status and diffraction will vary depending on the power of lens IOLs. Then coming to management of pseudophakia, we'll give specs, we'll do LASIK or advanced surface ablation. Then we can even implant we can even exchange intraocular lens in few cases if the refractive error is large. Then coming to the myopia, we have discussed hypermetropia and aphakia and pseudophakia. Now coming to the myopia. Myopia is short-sightedness. It is refractive error where infinity the parallel rays from the infinity are focused in front of the retina, where hypermetropia it is behind the retina. The focal point is behind the retina. Now it is in the front of retina, and when the accommodation is at rest. Okay, coming to the etiology, etiological types in myopia are again 5 types like we have discussed in hypermetropia: axial myopia, curvature myopia, positional myopia, index myopia, myopia due to excessive accommodation. Axial myopia, 1 mm increase in the axial length results in -3 diopter of myopia. Okay, curvature myopia, 1 mm decrease in radius of curvature of cornea results in -6 diopter of myopia. Then coming to positional myopia, it is because of anterior placement of crystalline lens in the eye. If it is posterior placement, it is hypermetropia, positional hypermetropia. Index myopia, where the refractive index is increased in the crystalline lens associated with nuclear sclerosis. Then coming to the myopia due to excessive accommodation, where accommodative efforts of the patient, if it is more, like in case of people who use excessive digital like video players or screens who see excessive screens and who do near work so much, this can happen. Grading, coming to the grading of myopia, we have low myopia, that is where the error is less than -3 diopter. Moderate is when error is between -3 diopter to -6 diopter. High myopia is when the error is more than -6 diopter. Now coming to the clinical types of myopia. There are 4 types again, like in the case of hypermetropia: congenital myopia, simple or developmental myopia, pathological or degenerative myopia, secondary myopia. Coming to the congenital myopia, we have myopia because of congenital abnormalities, genetic it is. Then coming to the simple myopia, or development, this is the most common variety. This physiological error and it is not associated with any of the disease. And coming to the causes of simple myopia, we have normal biological variation depending on the development of eye. Then we have axial type of simple myopia, where physiological variation in length of the eyeball happens. Curvature myopia, it is where underdevelopment of the eyeball happens. The predisposing or precipitating factors of this myopia include genetic role. There is a genetic role, and it is AD, autosomal dominant type of inheritance. Then coming to the theory of excessive near work. Excessive near work is also predisposing or precipitating factor for it. There can be limited outdoor activity, not using proper glasses. Role of diet is also a predisposing factor. All of these can be the predisposing factors. Now coming to the clinical features, coming to the symptoms under clinical features, we have poor vision for distance, short sightedness. So the short distance the person can see, and the long distance he will not be able to see. Okay, asthenopic symptoms occur because of the eye strain and headache, because of the eye straining. Coming to the next symptom, it is half shutting. It is like pinhole vision. When we see the objects under a small hole, they will be more what is it called, more clearly visible. So for that kind of thing, normally a person closes his eyes partially to be able to see better resolved image. And there will be psychological outlook change. If it is more common in children who become introverts, studious, and develop little interest in the outdoor of activities, because outdoor activities need that far vision. So the child might become introverted, studious, and disinterested in outdoor activities sometimes, not always. And then coming to the signs of myopia, there are prominent eyeballs. Large eyeballs are present. Anterior chamber is slightly deeper than normal. Pupils are large and a bit sluggish reacting. Coming to the fundus, it is normal. Normally fundus is mostly normal. Rarely it is temporal myopic crescent is seen in the fundus. The diagnosis is by objective refraction by retinoscopy and autorefractometry, and subjective refraction. Coming to the pathological myopia, we have discussed one clinical variety of myopia, that is simple myopia. Coming to the pathological myopia, the causes of pathological myopia can be role of heredity. It is like familial in most of the cases, more common in certain races like Chinese, Japanese, Arabs, Jews, etc. And it is more common in women than men, and it is mostly autosomal dominant. And it is linked to genes like 18p11.31, 12q21.23, etc. Then coming to the role of general growth processes, these two things which are the main factors contributing to pathological myopia. First is role of heredity. The second is role of general growth processes, where there is lengthening of the posterior segment of globe and it only commences after the period of active growth, and it ends with the termination of active growth. If there is nutritional deficiency, debilitating diseases, or endocrine disorders, um, in general health, these growth processes will be disturbed. So there can be this stretching of sclera. All of these things will genetic factors or general growth processes will contribute to stretching of sclera, and the features that we see in pathological myopia are increased axial length, degeneration of choroid, degeneration of retina, degeneration of vitreous. All of these things occur. Coming to the clinical features, the symptoms under clinical features can be defective vision, floaters will be there, difficulty in night vision can be there, photophobia can be there, flashes of light may be reported. And then coming to the signs, there will be prominency in eyeballs, cornea will be large, anterior chamber deep, pupils are slightly large and react sluggishly to light, like as in simple myopia only. But the magnitude of refractive error, it increases rapidly, in most more than -6 diopters, and finally may vary from -10 to -40 diopters as well. It can go till -10 to -40 diopters. Coming to the fundal examination, the optic disc appears large and pale at its temporal edge. It is a very characteristic and there is a characteristic myopic crescent present. Sometimes peripapillary crescent encircling the disc may be present. Coming to the degenerative changes under fundus examination, there can be degenerative changes in the retina and choroid which are observed. The changes are tessellated or tigroid fundus, where diffuse attenuation of RPE leads to visible choroidal vessels. Then we have Foster Fuchs spot, dark red circle patch due to subretinal neovascularization and choroidal hemorrhage. There can be lacquer cracks, which is because of the rupture of RPE branch membrane complex. There can be T/Y sign, which is due to exposure of central retinal artery and vein for variable distance posterior to their primary bifurcation. There can be cystoid degeneration, lattice degeneration as well, and we can also see posterior staphyloma or Scarpa's staphyloma. We can also see degenerative changes in the vitreous and posterior vitreous detachment. Visual fields can sometimes show ring scotoma. ERG, electroretinography may reveal subnormal electroretinogram due to chorioretinal atrophy. The complications of myopia can be rhegmatogenous retinal detachment, complicated cataract, vitreous hemorrhage, choroidal neovascularization, strabismus fixus convergence, primary open-angle glaucoma. And this comes under pathological myopia. Then coming to the secondary myopia, under secondary myopia we have index myopia, curvatural, positional, consecutive myopia, and pseudomyopia. Like we have myopia of prematurity, drug-induced myopia. The drugs which induce myopia are cholinergic drugs, steroids, and sulfonamides. Treatment of myopia is done by optical treatment, which comprises of concave lenses prescription. Then there is basic rule of correcting myopia, which is slightly different from hypermetropia, where the minimum acceptance providing maximum vision. This is the principle. Okay, now minimum acceptance providing maximum vision. Whatever is the minimum acceptance that the patient, like how should I explain it? If the patient is comfortable, the most comfortable thing that a patient accepts very easily, providing maximum vision. Okay. which will provide highest vision. This should be the principle of prescribing. Contact lenses can be used in high myopia cases to avoid peripheral distortion and magnification produced by strong concave spectacle lens. Okay, we can also use low vision aids for progressive myopia. Then preventive measures can be therapeutic interventions using atropine drops, pyrazine gel, which is atropine drops, low strength 0.01% instilled at night, and pyrazine 2% gel applied twice a day. Okay, general measures or just visual hygiene: avoid excessive near work or video display units. Normally, avoid screens and increase the outdoor activity in the daylight. Balanced diet, early management of associated diseases. Then genetic counseling can also help in case of genetic pathology, like genetic predisposition for myopia. And the next things which are astigmatism, anisometropia, anisocyania, accommodation and its anomalies, then digital eye strain, astigmatism, treatment, different methods of correcting refractive errors. All of these things we'll see in the next part of this podcast.